Hello, everyone. It's Dr. Locklear here, and I'm coming to you today with Exemplar on mobility related to MS, and we're talking about Exemplar 13D, multiple sclerosis, which still falls under mobility because it is a very debilitating disease related to your muscles and movement, and eventually the person becomes bedridden and dies of secondary causes such as infections and things like that. It's a difficult disease and it's over a long process as well. So, what are our learning outcomes? We want to talk about the pathophysiology of multiple sclerosis or MS, and I'll refer to it as MS as I go through. What makes this particular situation happen? How does it occur? Uh, what's the cause behind of it? The etiology. What are the risk factors? Can we prevent it? Can it be cured? What do we see with a patient that has MS? What kind of clinical manifestations present itself? How is it diagnosed? What diagnostic tests are run or labs, blood work, stuff like that? What does the interdisciplinary team need to do when they're collaborating care for this individual? As they become more debilitated, they need a lot of care because they lose their ability to perform their ADLs. What are the considerations for care of the patients with MS across the lifespan? It occurs at different ages and it can last for years. And so at different ages, people are affected by it differently. And how do we apply the nursing process to provide culturally competent care to these individuals? How do we address their individual needs? How do we assess? What are we looking for? What nursing diagnoses are pertinent? How do we implement the interventions? And what do we do when the interventions don't work? And of course, we always need to go back and evaluate. So let's get started. So, what is MS? It's an immune mediated disorder of the central nervous system and it attacks the myelin sheath. So these immune cells kind of start attacking the body and they attack a particular site called the myelin sheath, which surrounds the nerve cells. So it's kind of a protective uh, layer of tissue there so these nerves aren't exposed. It causes decreased transmission of your nervous system. So the neurons basically, when they're firing between the synapses, and that's where the firing occurs, it can't happen there because this myelin sheath is destroyed. Myelin forms a fatty insulating layer around the nerve cells to increase the speed of the electrical transmission. So when you have symptoms of MS, you see where you are affected with your movement and your neurological system because this firing cannot occur. Symptoms of MS often go into remission after the initial manifestation of the disease, and it makes diagnosing MS difficult because once you have like a major episode, then you can go into remission and not have another episode. So it may be missed that it's actually MS, but while the diagnosis is being missed, that myelin sheath is being attacked by the immune system and continued destruction occurs, which makes it even worse. Each individual affected by MS experiences a different set of symptoms and a range of severity of problems depending on how damaged the nerves are. So, what is the pathophysiology? So, we have axons and demyelinization, we have lesions, oligodendrites, and plaques. And so, we're going to talk about these. So, each axon or the nerve fiber in the central nervous system, it's covered by this myelin sheath. It's a protective layer around the nerve, and it also increases the efficiency of the electrical impulses that go from neuron to neuron. Without that electrical impulse, it affects our movement and our neurological system just doesn't work right. In some individuals, cells of the immune system, such as lymphocytes and macrophages, they cross the blood-brain barrier. They attack and destroy the myelin sheath in a process called demyelination. And so this is where the body is attacking itself, okay? So demyelination. This causes inflammation, and so when we have inflammation, that impedes it even more from being able to work correctly because there's inflamed tissue around it and it can't fire. This inflammation causes formation of lesions. So you have these lesions of areas of inflammation and damage in the surrounding area. And in addition to the myelin sheath, the underlying axon, as well as the oligodendrocytes. Now, these are cells that produce myelin, so we don't want them destroyed. They may be damaged by the immune system as well. So unlike damage to the myelin sheath, which can be repaired by the oligodendrocytes, these repeated attacks over time make that process irreversible. And so once these oligodendrocytes are continuously attacked, they can't do their job eventually either. So the damage is done and the myelin sheath can't repair itself. Repeated attacks on the myelin may stimulate the formation of scar tissue or plaques, which causes permanent damage. Axon damage and a lack of myelin disrupt nerve impulses in the central nervous system. So when we can't have our neurons firing from one neuron to the other, telling them what to do, telling us to move, how our body should work, then we lose mobility. So we have this damage in the central nervous system, and these nerve impulses are disrupted. It causes neurological symptoms such as muscle weakness, visual disturbances, balance, and coordination problems as well. Eventually, the patient is not able to walk. Now, on this slide, it gives you the etiology and it gives you the classifications of MS, and there are 4 different classifications. So it's generally characterized as an autoimmune disorder. Now, auto means self, so the body is attacking itself. The events that trigger the immune response against the myelin sheath that are unknown. They don't know what causes that. They don't know what causes the body to start attacking itself. But there are links found to environmental, like toxins, infectious and genetic factors, and it may be related to the geography, sunlight, and again, environmental toxins such as poisons and gases and things like that. Some scientists believe that vitamin D plays a protective role as well, and so you want to make sure that maybe the patient's taking in enough vitamin D in their diet. Also, other theories promote that it could be from measles, herpes virus, rubella, chlamydia, and Epstein-Barr virus. So what are the 4 categories? You have relapsing, not relaxing, relapsing, remitting MS, primary progressive MS, secondary progressive MS, and progressive relapsing MS. And so with the relapsing remitting, this is the most common form. You have flare-ups, and then you have partial or complete remission, and it can last for days or months, and then remission may last years or months. Primary progressive, this is slow but nearly continuous. So there's really no distinct remission there. It just, once it goes into primary progressive mode, the person is constantly dealing with the symptoms. There's no remission. Secondary progressive, this develops in about half of the patients that are untreated from relapsing remitting MS. It's a progressive form of disease, and you have initial periods of the first category, relapsing. Progressive relapsing, usually very rare, steady worsening with acute relapses, and period between relapses involves progression and not remission. So you're really going to see patients that are in the first 2 categories, relapsing, remitting, because that's the most common, and then the primary progressive. And you usually see that as the disease progresses. Again, the etiology, again, it's an autoimmune disorder, and here are some factors that may lead to it, but they don't have no definitive uh, cause. So what are the risk factors? First degree relative with MS, so it could be genetic, usually around age 20 to 40, more likely men than women. Known primarily affects those of Northern European ancestry, so this could be some genetic link because it's specific to Northern European. Smoking increases the risk. And so, because smoking causes vasoconstriction and it can affect circulation, which affects everything about our body. Smokers with MS are at greater risk because it will cause the disease to escalate. So when we're educating our patients, we need to definitely talk to them about stopping smoking as well. There is currently no cure, and there's no definitive way to prevent MS because they really don't know what causes it. And usually, 100% of the time, you don't know you have MS until you have a flare up. You may have some mild symptoms like muscle weakness or just some coordination issues with using your hands and stuff like that. But until you go into a full episode, they're not really able to diagnose it. It may decrease risk when you avoid smoking or take vitamin D supplements or move to a geographic area that has less toxins such as air pollution and things like that. On page 937, it talks about focus on diversity and culture, and it talks about parasites and how they weaken the immune system. So individuals with an increased likelihood for parasitic infections, such in countries where they don't have clean water, are less likely to be diagnosed with MS. It says that as these countries develop and become more proficient with their clean water and decrease parasitic infections, improve sanitation and decreased exposure to parasites, the diagnosis of MS is on the rise in these countries. So, it's amazing how parasites can weaken the immune system, which could possibly not trigger an MS episode. What are the clinical manifestations? So sometimes, people experience different things, and there's a array of things listed here for you on 937 under common signs and symptoms, and some are listed here on your slide as well. Make sure that you read this section here carefully too. But clinical manifestations depend on the location and the severity of the damage in the central nervous system. So you may see effects in your arms and hands or your feet and legs or your whole body. No two patients have the same set of symptoms because we're all individualized. And again, I use the example, if you had 5 stroke patients, your care for all 5 of them would be different. Many manifestations are common to other diseases. It may be persistent or go into remission or become exacerbated, and exacerbated means that it's getting worse. True exacerbation lasts about 24 hours, and paroxysmal attacks, these are symptoms that last less than 24 hours. Relapses may be triggered, and here's a list for you, and there's a very detailed list on page 937 as well. So read those too. Fatigue, stress, infection, increased body temperature, and there's many more listed here under common signs and symptoms. You'll see lack of coordination and balance, unsteady gait, tremors, bowel and bladder disruption, visual disturbances, double vision, blurred vision, dizziness, headache, cognitive changes, anxiety, depression, weakness in your limbs, seizures, breathing problems, itching, and something called an MS hug, which is a sensation of a tight band around the abdomen because it's affecting these muscles. Primary symptoms may lead to secondary and tertiary symptoms, and African American patients, older at diagnosis, more symptoms, more progressive, and this could be a genetic link. Hispanic patients, younger at diagnosis, fewer mobility, bowel, and bladder problems. And it talked about here about a pseudo exacerbation. So if you have an infection or increased body temperature, you may have what's called a pseudo exacerbation, which means a false. Pseudo means false. This is a temporary aggravation of symptoms that is directly related to the trigger of a possible infection or increased body temperature. Other clinical manifestations, these are listed here for you. And again, there's a detailed list in your page 937 as well. So who do we collaborate with? Nurses, primary care providers, a neurologist, and an immunologist, urologists, ophthalmologists, because it affects so many systems. They need to get their eyes checked. They need to go see somebody about frequent UTIs, about their lungs. And it's amazing that we have to go see so many doctors for so many specific things. PT and OT to help with the muscle weakness, and of course a psychiatric eval if you're dealing with the depression and anxiety. Nutrition, because we know vitamin D plays a role, so we want to make sure that the patient is getting foods healthy with vitamin D. Nursing care, we want to focus on symptom management, patient teaching, I can't talk, I'm sorry, emotional support, and referrals. So OT, PT, speech, an array of things. No single diagnostic test is used. They will look at an MRI to see if maybe there's any lesions, especially up your spine, where the most of the your neurological system is located. It comes from your spine area. You know what I mean. Look on page 937. An MRI is used to detect the presence of lesions in the central nervous system. A lumbar puncture or spinal tap is used to obtain a sample of the cerebrospinal fluid, and then it's tested for elevated immunoglobulins, which indicate possible infection. Okay. And on page 938 and 939, it talks about the multi-system effects of multiple sclerosis. Please make sure you read over this. Respiratory, you can have diminished cough reflex, respiratory infections, UTIs, difficulty chewing, bowel incontinence, constipation, because we know our bowels are very connected to our neurological system. And if our neurological system is attacked, we may not be able to have a bowel movement like we're supposed to. Please make sure you look at it. It goes over every system. And then on 939, it talks about the clinical manifestations, primary symptoms, secondary, and tertiary symptoms. And you see some of these listed on 937 as well. And then clinical therapies. If I'm doing primary, I want disease-modifying therapies, assisted devices, corticosteroids to help reduce the inflammation around the myelin sheath, and that may help the neurons fire better. Antibiotics for any secondary infections, analgesics for pain or any type of fever, physical therapy, nutrition and fluids, antidepressants to help, like Ativan or some low dose Prozac or something like that. They don't really use Prozac a lot anymore. It has too many side effects. Surgery is not a common treatment. Patients with specific symptoms, for example, patients with severe pain may undergo a rhizotomy, which selectively destroys problematic nerve roots in the spinal cord. So they'll actually go in and sever these and kind of kill them off, so to speak, so they don't work anymore. You don't have the pain from it. Musculoskeletal surgery to lengthen or transfer tendons or muscles, and placement of a pump for intrathecal bacillin therapy, which will help with some of the inflammation there. And it lists the beta interferons on page 939 for you. And so these are Avonex, beta-seron, Extavia, and so forth. And so when they are getting these interferons, to help with the inflammation. Our responsibility includes assessing liver function, CBC for baseline every 3 months to test for side effects, assess the injection site for signs and symptoms of inflammation, infection, monitor changes in the patient's condition and function to assess for efficacy. And then it talks about copation, and this blocks the immune system's attack on the myelin sheath. And then it talks about galena, traps immune cells in the lymph nodes, making them unable to cross the central nervous system barrier. And then you have Tysabri, interferes with the movement of immune cells across the blood-brain barrier. It is only used in patients who cannot tolerate other treatments because it increases the risk of developing a fatal brain infection. So some of these medications have side effects for them. The list goes on page 940. And you as a nurse, you may see baclofen. That drug's been around a long time. And so it's administered to reduce spasticity in patients with a variety of disorders, including cerebral palsy, traumatic spinal cord injury, and MS. So it helps reduce the inflammation. And like I said, that drug's been around for a while. Safety alert on 940, disease-modifying therapies may cause damage to a fetus. Therefore, they are not approved for women who are pregnant. Women who want to become pregnant should discontinue their MS medications before attempting to conceive. These drugs are also not recommended during breastfeeding. And then on table 13-6 on page 940 are medications for symptoms of MS. And you'll see the symptom, and then you'll see the medication. Dexamethasone and methylprednisolone, these are all steroid-type medications. And then you have something for fatigue, amantadine, spasticity, baclofen, constipation, Biscodil, Docuset sodium. These can be bought over the counter. Pain, carbamazepine, clonazepam, gabapentin, phenytoin. And these are also seizure medications too, so the patient has to be monitored for lab values when they're on carbamazepine and clonazepam, gabapentin, and phenytoin. Depression, bupropion, citalopram, duloxetine. Some of these are like your Prozac and Paxil and stuff. UTI, ciprofloxacin or Cipro. Bladder dysfunction, these oxybutynin, that's a very common one. Tremors, isoniazid, and that's something that what you call INH, and you see that sometimes in patients with TB as well. Some complementary approaches. You want to look at acupuncture, and I would love to do acupuncture and see if it really works. Aromatherapy, horseback riding. I thought that was really unique that they added that in there. Massage and prayer, whatever your faith-based practices are. And so some people may do multitude of things. Herbal remedies may benefit specific symptoms, but they may interact with steroid medications or stimulate the immune system. Low dose naltrexone may improve the quality of life, but no impact on physical symptoms. And before we get to lifespan considerations, I want to go back to page 940 and look at the non-pharmacological therapies. I don't know if I missed a slide, I might have, but physical therapy to help with walking, rehabilitation. You want proper nutrition and fluids, good lifestyle habits, occupational therapy to help with activities of daily living, speech as your muscles become weaker from the lack of being appropriately stimulated by the neurons. You can lose the ability to talk and swallow, so people are at high risk for aspirating their food and getting pneumonia as well. Cognitive therapy to help with the changes in the mental status. And then vocational rehabilitation. If you have a mild case of MS, you may still be able to work, but need some help to do that. Maintaining a healthy lifestyle through mild exercise, weight training. Fatigue is very common with MS, so getting plenty of rest, pacing yourself as you go throughout your day. Avoid excessive heat and to keep cool by staying in air-conditioned areas and drinking cold beverages. Symptoms may be exacerbated by increased body temperature. So a lot of these people with MS like to stay in a cool environment. Eating a balanced diet and staying hydrated, and then of course having vitamin D in the diet. And then lifespan considerations, 2 to 5% of individuals with MS experience symptoms before age 18. It's more challenging in children because they have other symptoms from other possible diseases. And you don't normally see MS in children. It is usually people age 20 or above. They have a higher rate of relapse, related problems, or reduced academic performance because of the cognitive changes, difficulty in family and peer relationships, a distorted self-image as they lose their ability to function. Pregnant women, you have to really think, I've got to come off my medicines. I could go into an exacerbated episode. And so, without the medicines, you are unprotected. And it says usually during the second and third trimester, you see these exacerbations. So this could be a very difficult time. It's a lot to consider when you have MS, especially if you're young and you have children. Older adults have more severe symptoms because the disease progresses with aging, and so the caregivers may require somebody to help because you become very debilitated and bedridden. The nursing process, so we want to follow and document the disease course, continued assessments, and emotional and physical support. So when we do our observation and patient interview, of course, we want to ask those questions, how is your gait? How is your posture? When did the symptoms flare up? What factors are affecting it? Are you in a hot environment? Where you work is a very high temperature, because that does happen. Sometimes people that work outside are in factories. Any other medical problems, any medications, and so forth. And you can see these listed here for you. Physical exam, weakness, inability to move and walk. Their affect. Affect is how you look on your face. Is it flat? Are you having difficulty smiling because your muscles in your face are affected? Balance and coordination. Are you leaning to the side? Are you unsteady? Are you falling during the exam? Hygiene, because you're just not able to take care of yourself. Is your speech slurred because you have a difficulty talking? Is your disability, expanded? And it gives you some scales here listed here, the expanded disability status scale, and then the general disability scale with a functional system. These are some tools that they use. These are your nursing diagnoses. They are listed on page 942. And you also have a safety alert. Patients with chronic or progressive disease such as MS are at increased risk for developing depression. Assess patients with MS for depression and suicidal ideation at each healthcare interaction. When you do your head-to-toe assessment, the first thing you should assess is level of consciousness anyway. So always assess that. Planning, there's several bullets listed for you here in your book, and you want to make sure that you're getting them the right services that can help them stay as active and functional as possible. Get enough sleep at night. If you're like all of us, we never get enough sleep, even without these diseases. These are our common goals. The caregiver will help from home health agencies, families, and friends. So these people definitely need a caregiver. They're not going to be able to take care of themselves as their situation progresses. Implementation, you want to look at safety, arranging the home for home health, making sure that the patient is safe because they're already so debilitated from their neurological weakness. They're at high risk for falls. They're at high risk for UTIs and constipation. So we want to, give them fiber in their diet. Maybe they need to take a DocuSet sodium every day. We want to teach them to use their incentive spirometer to keep their lungs open. The good thing to tell someone is to use the IS 10 times every hour. So if they're at home and say they're watching TV, tell them to use it every time they show a commercial, because they show commercials every 10 minutes on TV. Under implementation in your book, it talks about assessing relapse in multiple sclerosis. This is the ARMS questionnaire, and it gives you a link where you can find that questionnaire, and it looks at these specific questions. Again, we want to promote independent mobility. We want the patient to be as active as possible, as long as possible. Again, home safety, assisted devices such as wheelchairs and things of that nature. Promote self-care, and so they can take care of themselves as long as they can. People don't want to lose their independence. Facilitate referrals, and there's a list of referrals here for you, and I've already gone over those as well. Evaluation, so we want to evaluate that they're as mobile as possible for as long as possible. Make sure that you read over the care plan on page 944. If we have time, we'll go over this, and I hope we have time in class when we get to this lecture. Hopefully we'll be face to face by then.